So welcome to today's Crisis Jam. I'm Dr. Brian Sims. I'm the Senior Medical Advisor with the National Association of State Mental Health Program Directors, and I'm thrilled to be a part of this Crisis Jam today. We have an action-packed agenda set up for today, and I want to make sure that we get through it as best we possibly can to give everyone. So today is episode 132, if you can honestly believe that. We have reached that. And today's episode will highlight the ADA Act and mental health as given to us a little bit later by Haley Van Erem. And we'll give more information about her in just a little bit. So next slide, please. Just a reminder back to the Crisis Talk that when you go to this site, it is a wealth of information. You can go backwards in it, you can go forward in it, you can take a look at episodes that previously occurred, you can see the entire episode, you can also see what's yet to come. So it is a very, very, very information-packed site to go to. As always, we highlight the top 5 that are there, and they haven't really moved much. We still have the #1 at the special youth edition. I'm really proud of that, and just looking forward to watching the numbers actually increase from some of the other sites as well. Next slide, please. And again, our highlight in 3 weeks, episode 135 will be our 1-year celebration. 988 turns 1 with the Crisis Jam. And we're going to be favored with Monica Johnson, who is going to be the lead spokesperson on that particular Crisis Jam. We're looking also at potentially having several other speakers during that time. So stay tuned, folks. Make sure you are there for this episode 135. Next. And this is a slide to highlight the 988 team that you've heard about over the past weeks. They've been traveling all over the place. They just came out of Austin, Texas. This is really a team that we're following. And as we get more information, just to make you aware that they are there, they are sharing information, and they are being wonderful listeners with regards to information being given to them. Next slide. This is also reflecting a meeting occurring on reimagining the crisis response that occurred just yesterday. And we'll put some information or a link in the box if anyone is interested in additional information on this particular reimagining a meeting that did take place, like I said, yesterday. Next slide, please. And this, and we always highlight certain articles of interest. And this was one that we saw that talked about the US mayors actually getting together in what they refer to as an unprecedented mental health crisis being their top concern. And this is really encouraging overall to say that they're beginning to have the dialogue that is necessary to get a change to occur. Next slide, please. Also on this, to highlight awareness of things that are going on here and now today, either through George Floyd or through other issues that have happened, just to highlighting that it is still happening. It shows that most people shot by police in Massachusetts are mentally ill or having a breakdown in terms of the assessment of it. So it really is at the top of our discussion format and still becomes news that we need to keep at the top of our measure as to justifying why 988 and why our crisis services are so critically necessary. The next slide. And a reminder of the 988 crisis census store offerings. We have all of these free items that are there. I mentioned this before, but I've received my box full of census material, and regarding 988, I'm all set to do what we need to do with that material. And that is based on the fact that we still need to get the word out to everyone. We need to distribute this material. So don't forget, you can order up to 326 pieces of material. Also a reminder about our t-shirts. When you sit in a hot seat, you can get one of these t-shirts or a hat. It can be short sleeve, it can be long sleeve. You can have different sayings that are placed on it. So just an awareness that if you would like a free t-shirt, come on and be on the hot seat. Otherwise, you can go into the site and purchase one as well. Next slide. I want to highlight one of the persons that is going to be with us today, and that's Dr. Kenneth Thompson. He recently wrote an article on hanging in there, mental health and well-being in the aftermath of COVID-19. It's just kind of a prelude to this wonderful gentleman who we are going to meet next. Next slide, please. And Dr. Thompson, are you with us?
Yes, I am.
Oh, I love that.
Good morning, good afternoon.
And good day to you, sir. Good day to you. Welcome to the Crisis Jam Hot Seat. And I think you may be aware of how this hot seat operates. You know that what we'll be doing is kind of like Who Wants to Be a Millionaire? We'll kind of ask a question of you, sir. You have options at this point. You can either choose to answer the question as you know it, or you can go to the audience, or you can even phone a friend. So with all of that in mind, I do want to remind you that right or wrong, you will get your choice of a t-shirt or a hat or otherwise. So if you're ready, let's go ahead and move forward. Now, this one's going to be a little different, Doc, because what we're going to do is actually give you the question, and we're actually going to throw a clue your way. If that's
good.
All
good.
Right. So let's just start with it. What was the name of the lead plaintiff in the landmark 1999 U.S. Supreme Court ruling? And let's go ahead and show the clue now. So to give you an additional clue, after 20 years inpatient, she moved on and into her own apartment, worked as an artist, and exhibited her boldly colorful pastel and acrylic portraits in Georgia galleries. She became a public advocate, and in 2011 presented one of her paintings to President Obama in the Oval Office. So that's your clue. So at this juncture, we're going to put it out to the audience so that the audience can put their responses in, and we please encourage you all to answer the question. And Doc, we'll turn it back to you. Would you like to address it on your own? Would you like some assistance from the audience? You can certainly wait until they do. Choice is yours, sir.
All right. Well, I'm going to just say I didn't know that about her and what happened after her stay in the inpatient hospital. But I'm not surprised to see that Jean Olmsted did some amazing things, including presenting art to President Obama.
All righty. So am I to say that your choice is Jean Olmsted, or would you?
You got it.
Okay. All righty. Well, let's just see, for the sake of argument, it looks like the audience is pretty much on your side. And calling it, at least 72% of them said that it's Jean Olmsted, and a lesser amount of Lois Curtis, and then kind of evening out on the last two options. Well, then, if you are ready, sir, and you are locked in on your answer, let's see what the answer actually is. And unfortunately, it is Lois Curtis.
No, geez.
And as you can see from the clues, it was kind of kind of tricky, if you would have it, because many of us are familiar with certain portions of the names, and they were kind of thrown in there to kind of throw people off. So anyway, thank you, Doc. As a matter of fact, you
That was cool.
go after the t-shirt, sir. It's a sincere pleasure to have you join us in the hot seat. I'm going to go to the next slide, mainly because I want to let everybody know that we'll be talking to you very shortly, Doc, okay, during our session after the keynote speaker. And the next slide, I just wanted to show you that it is Lois Curtis. And this was a quote from her that, "Hello to all the people living in institutions. I remember you." Such a powerful statement from a powerful, powerful lady. Next slide, please. And we are looking at that particular event with the 2023 Olmsted versus Lois Curtis anniversary event coming up. And we'll try to put some information, but it's a reminder that it's actually tomorrow from 12 to 1:30 in virtual and live streamed for those who are interested. Next slide. And we have now come to our keynote presentation, and it's my pleasure and my honor to introduce Haley Van Erem. She's a trial attorney in Civil Rights Division, a Special Litigation Section of the U.S. Department of Justice. And Haley, I will turn it over to you. Thank you so much for joining us today.
Thanks so much, Brian. Can you all hear me?
Yes.
Okay, and I apologize, I'm not on video. It was working on my Zoom right until I joined this meeting, and then my video has stopped. But so I apologize about that, but I'm glad you can all hear me. Thank you all so much for having me today. It's great to be here. My name is Haley Van Erem, and I'm a trial attorney with the Special Litigation Section of the Civil Rights Division of the U.S. Department of Justice. And our office enforces the civil pattern or practice police misconduct statute and the ADA. Our section handles solely systemic investigations and cases, and we conduct in-depth investigations and issue findings reports, some of which I will discuss today. The Civil Rights Division has focused efforts to address the critically important issue of needless criminal justice system involvement for people with behavioral health disabilities. We know that people with mental illness and substance use disorders make up a disproportionate share of police interactions and jail populations. And we know that carceral settings are not conducive to and often exacerbate mental health recovery. But people with behavioral health disabilities are often pulled deeper and deeper into the criminal justice system through a revolving door of repeated jail admissions, minor probation violations, and continued criminal justice system involvement with very few off-ramps into the community-based services we know can stop the cycle or prevent it from occurring in the first place. So to the extent that discrimination is perpetuating or contributing to this cycle, it's a priority for the Civil Rights Division to address it. So I wanted to give you a brief overview of some of our recent work in this area, just to give you so you can kind of see what we're doing in this space. So if we can go to the next slide. First, I wanted to talk about the Louisville Metro Police investigation. On March 8th, 2023, DOJ issued a finding that Louisville Metro government and LMPD violate the ADA in their response to people with behavioral health disabilities. Specifically, we found that the ADA was violated by unnecessarily deploying police to behavioral health calls. It's the first time the Civil Rights Division found that unnecessary police responses during behavioral health episodes violates the ADA. And we found that LMPD officers are the primary and generally the sole responders to situations involving behavioral health issues in Louisville, even in instances where safety does not require a law enforcement presence. It really challenges the premise that police should be the default first responders for behavioral health calls. Specifically, we said, while some calls necessitate a primary law enforcement response because of violence or threats of violence, thousands of calls per year could be safely and more effectively resolved through a response by behavioral health professionals, such as a mobile crisis team, or with co-responding behavioral health professionals, along with appropriately selected and trained officers. And so our report discussed not just how police were not always the right response, but how a police response is in Louisville ineffective and harmful. And we really tied the lack of the behavioral health response available in Louisville to criminalization of mental and behavioral health disabilities. We noted that police contact often leads to arrest and incarceration. For example, we said in the report, Louisville Metro and LMPD have subjected many individuals to an unnecessary or overly aggressive LMPD response during a behavioral health episode, violating the ADA. And as a result, these individuals have faced, among other consequences, unreasonable uses of force and avoidable arrests. And one of the things we looked at here was we looked at the dispatching system and how that plays into these violations. And we found that the 911 dispatching operations did not ensure that call takers obtain adequate information from callers regarding behavioral health crisis or sufficiently memorialize the information for dispatchers and responding LMPD officers. And we found that that was one of the reasons why this discrimination existed. So if we can go to the next slide, I'll talk a little bit about an example we highlighted. We highlighted a number of examples because some of the information we reviewed include a lot of data, as well as a lot of in-depth incidents into behavioral health needs where people came into contact with law enforcement. So one of the examples we talked about was a Black man with an apparent behavioral health disability who experienced more than 25 LMPD encounters in under 2 years for behavioral health related reasons. We talk in the report about one October 2021 incident in which LMPD officers responded to a report of a disorderly person panhandling. When they responded, they found this man walking the street with his shirt off. He spoke to the officer in a way that was difficult to understand. The officer told him he was not making any sense. It was clear that the responding officers were familiar with the man. They ultimately took him to the hospital and they charged him with possessing drug paraphernalia. He had subsequent LMPD encounters after that October 2021 incident, including on January 5th, 2022, where he was encountered law enforcement, again, as a result of his behavioral health needs. He was charged with criminal trespassing and failure to appear, and he was taken to Louisville Metro Detention Center, where he unfortunately died 4 days later. We found that in our review that these encounters, including the two that I mentioned, but the other encounters as well, could have been handled by a behavioral health focused response concurrently with law enforcement, and some did not need police involvement at all. And so we can go to the next slide. So one of the things we talked about in the report is that Louisville could make reasonable modifications to avoid this discrimination by doing things such as deploying alternative responses, including by expanding mobile crisis response and modifying dispatch policies, enhancing coordination with the crisis hotline and other services, and modifying LMPD's CIT program to ensure that when officers do have to respond, they are equipped to do so. I just want to be clear, this is a really fact-specific inquiry. So what may be reasonable in one place, like Louisville, may not be reasonable in other places, depending on, the infrastructure that's been set up. In Louisville, we entered into an agreement in principle with Metro government, who committed to resolving the department's findings through a court enforceable consent decree with an independent monitor. And the next step for us is to really engage in negotiations to achieve a consent decree, which is just really a settlement agreement that is entered into in federal court and overseen by a federal judge and an independent monitor. And I'll talk a little bit later about how some of the work and some of the existing consent decrees we have also relates to these issues. I also wanted to highlight a very recent investigation, findings from our office on the next slide, which is on this last Friday, June 16th, 2023, we found that the city of Minneapolis and Minneapolis Police Department violates the Americans with Disabilities Act in their response to people with behavioral health disabilities. We found that the city primarily relies on Minneapolis Police Department officers to respond to calls about people in need of behavioral health attention who pose no threat of harm. We really found that many calls that they respond to do not require a police response. For example, our review revealed that MPD responded to a call from a man who wanted to tell officers stories about his life and had to be advised by officers that 911 was for emergencies. They responded to a call about a woman with schizophrenia who believed people were stealing her identity, and to a call from a grandmother about her grandson who had depression and was upset due to a family issue. Such calls could be safely resolved with a behavioral health response, such as a mobile crisis team. We also found that the city's treatment of people with behavioral health disabilities stands in stark contrast to the experience of people in need of medical assistance in Minneapolis. Whereas a person in medical need receives a response from trained EMS professionals, the people with behavioral health needs frequently received a response from armed police officers with limited training in addressing those needs. And we also found that the city's failure to provide appropriate emergency response services for people with behavioral health disabilities has had grave consequences, including serious injury and death. And so we found, similar to in Louisville, we found that Minneapolis could make reasonable modifications to avoid this discrimination, including expanding and improving its existing alternative response program. We talked a lot about the existing relatively new alternative response program and how that could be expanded. Also by reforming its dispatching processes and procedures, and by improving behavioral health related training for MPD. So these are a couple examples of our most recent investigations that really address this issue. And, in both of them, we hope that we are able to achieve a consent decree where we can really work with the cities to reform these issues and make sure that there are adequate behavioral health crisis response services available. Okay, and on the next slide, I wanted to talk briefly about some other related ongoing investigations. I'm glad that Lois Curtis was mentioned earlier, because some of these are Olmstead investigations as well, and they're really related to the investigations that I just discussed. So in Kentucky, we have an open investigation into the state, looking at whether the state provides community-based services necessary to avoid needless psychiatric admissions for people in the Louisville area. This investigation is being conducted under Olmstead and the Americans with Disabilities Act. And, you know, we're also looking, both of them, both this and the investigation that I mentioned into LMPD in the city of Louisville are looking at the services that are available to people in the Louisville area, and whether if people are cycling in psychiatric hospitals, whether there's criminal justice involvement in that as well. And then similar to the investigation in Louisville and Minneapolis that I mentioned is an investigation we have into Phoenix, looking at whether the city and the Phoenix Police Department violates the Americans with Disabilities Act by unnecessarily deploying police to behavioral health calls. And then we also have an ongoing investigation into Oklahoma, where we are kind of combining both Olmsted and the other investigations I've mentioned, looking at city and state police, investigating the state and a city police department, Oklahoma City, to examine whether the state fails to provide community-based mental health services to people, leading to unnecessary psychiatric facility admissions and police interactions. This allows us to look a little more upstream in the cycle of police involvement to the role that community-based services may play in these interactions. Okay, and then on the next slide, I wanted to talk a little bit about an ongoing consent decree that we have and some of the results that we can see in these consent decrees. So in Baltimore, we issued findings in 2016, and we entered into a consent decree with the city of Baltimore in 2017. There we had findings regarding stop, searches and arrests, discriminatory policing, First Amendment violations, and excessive force. And we ended up having a force claim under both the Fourth Amendment, which is about the use of excessive force, and the Americans with Disabilities Act. We found that by routinely using unreasonable force against individuals with mental health disabilities, BPD officers repeatedly failed to make reasonable modifications necessary to avoid discrimination in violation of the ADA. And we found that officers were failing to de-escalate and often escalating instead. And so as part of, and in the findings, we noted that officers weren't requesting an officer trained in handling crisis events or a mobile crisis team, but instead would handcuff and detain and often use force against people with mental health disabilities. So in our consent decree, which again was entered into in 2017, we had a number of requirements that really speak to the behavioral health services available in Baltimore. We required Baltimore to do a gap assessment in the behavioral health service system. This was really demonstrating a recognition that avoiding ADA violations starts upstream of police interactions. The gap analysis was published in December 2019, and the city developed a gap analysis implementation plan aimed at reducing unnecessary police encounters with people in crisis. The city also implemented a 911 diversion pilot with a crisis line in 2021, and is working to expand mobile crisis capacity to 24/7 and to meet national standards. We also, in the consent decree, required a policy preference for least police involved response possible, which was also new at the time for the department. And we focused on better training and policies for dispatch to get more calls diverted from police, requiring CIT training for dispatchers, requiring them to limit police involvement in crises where appropriate, and where police were necessary, requiring dispatchers to try to get a CIT trained officer on the scene. Okay, and then one other, I know short on time, one other brief matter I wanted to tell you about was the Alameda County letter of findings, which was more upstream and not as focused on police. It was focused more on the mental health service system in the jail. This was in Alameda County, California, and we found the county was violating the Americans with Disabilities Act and the Constitution, finding that the county failed to provide services to people with mental health disabilities in the most integrated setting appropriate to their needs, again under Olmsted, and finding that it was unnecessarily institutionalizing people at John George Psychiatric Hospital and other facilities. And then without connection to community-based services, people were returning to the hospital in crisis again and again, and being admitted to jail. And so we found that, and we also found that unconstitutional and unlawful conditions in the county jail were exacerbating the cycle of criminal justice involvement and preventable hospital admissions. We're currently in negotiations with the county now, but the remedies we outlined, we're really focused on increased community-based services. So I know I went over those very quickly, but I wanted to be able to, and on the next slide, I have some contact information on our website. I wanted to be able to kind of briefly tell you some of the matters that we're looking at and some of the work that is so related to the areas that you all focus on. And if you can go to the next slide. And so all of the documents related to these cases are on our website, which I've listed here. And we also have a complaint portal here. I haven't been monitoring the chat very well, so I apologize, but I will put the links to the LMPD and the MPD letters in the chat. And I also have my contact information, my email here. We're always looking to connect with experts in the field. And so, you know, we want to stay current on the different programs that people are successfully implementing. So I really encourage you to reach out to me.
Wow.
And yeah, thank you.
Thank you so much, Haley. And in actuality, I'll go to the last thing that you said. You were not able to monitor the chat box, but you must have read minds, because this last slide, I think, was what people were looking for. And your mention about where to find the links were perfect timing. So thank you so much for a very comprehensive overview in such a short period of time, but just phenomenal. Thank you again. I want to move to the roundtable discussion at this time. We have two outstanding individuals who are ready to give some comments, some brief comments on the presentation. We'll start off first with Mary Giliberti. She is the Chief Public Policy Officer with NAMI. Mary, if you'll go right ahead, please.
Sure. Actually, I'm the Chief Public Policy Officer of Mental Health America. So I just want to clarify that. And, you know, my comments are really going to be around how I can tie together some of the Olmstead discussion earlier and the lessons learned from that case with the findings letters that you just heard about. For those of you who aren't familiar with Olmstead, it held that needless institutionalization violated the ADA. And some of the lessons I want to talk about are the collaboration, the planning, the resources that were needed to implement Olmstead. Like, what came next? As Haley said, like, this is the first step, the findings letters, then you have the consent decrees, but what can all of us do? Because we're all stakeholders here. And how did we get involved in Olmstead, and how did that make a difference and could make a difference here? I was privileged to work on the Olmstead case. I worked on amicus briefs that brought lived experience to the court. My colleague at the Bazelon Center at the time was Jennifer Mathis. She is now at DOJ working with Haley on these, and I just want to acknowledge the decades of work that Jennifer has done on these issues. And there were some cases prior to Olmstead that talked a little bit about these issues, but Olmstead was a landmark decision. And I really think these findings letters are watershed moments for us in the community who've been working on crisis issues. And in Olmstead, the court really articulated what was at stake. You know, if you're in an institution, you can't work, you can't get an education, you can't have social ties. It went through all those things, just like the findings letters showed all the circumstances where we didn't really need police, but police showed up, and ultimately held that needless police involvement is a violation of the ADA. And what was really important in both instances is the people involved, right? We say good facts make good law as lawyers, but really what we're trying to say is the stories of human beings really matter and drive this work. So whether it was Lois Curtis and, you know, this amazing advocate and artist, or the gentleman here that really, for me, just brought it to the surface was the person who died in a Louisville jail because of needless law enforcement involvement. Just bringing back to the fact that you can't have Olmstead implementation. You can't have people out of institutions like jails unless we have a behavioral health response to crisis, right? So when Olmstead was handed down, the court said, if you have a plan, that's a defense. If you have a plan on how you're going to increase community services, how you're going to move people off the wait list. And so there was a tremendous amount of collaboration across the federal government, across states, across localities, technical assistance, training, stakeholders coming together. And all of that's going to be needed here if we're really going to realize the promise. And we as advocates always talked about the promise of Olmstead. If we're going to realize the promise of 988 and the promise of a behavioral health response, we have to have all that coordination, and then we have to have all the resources. And there are some cautionary tales in these findings letters. So for example, they talk about in Louisville, there was a living room program that was working great, but it got cut in budget cuts. in Minneapolis, there's a pilot program, but it's not serving everybody. It's not serving the people who need it, many of those folks. So we know that we need to look at resources. When Olmsted was implemented, Medicaid plans were looked at, all the different ways we could get financing. And that's going to have to be just as important here. How are we going to be able to finance the complete system that we need? And stakeholders got really engaged in that. And that's what we have on this call, right? All of us, officials, advocates, people with lived experience, and that's going to be needed. And there needed to be a plan. And I think as you look at the findings letters, what struck me was that homeless shelters and behavioral health settings were calling the police. That to me indicates a need for prevention. And in Olmsted, we went from looking at people in facilities to how do we keep people out? And we're going to need prevention here too. And finally, I just want to note intersectionality. The findings letters talk about the intersection of race and disability here. I hope the consent decrees and all the work that we do will focus on equity. How do we make sure that people responding reflect the community? How do we make sure that people have proper training? When we do awareness, how do we address the fact that the issues on people's minds is whether police are going to come or not? So all those things have to come into it. So I hope as Justice looks at consent decrees, as we all do our work, we'll keep equity up front in mind. And so we can realize the promise of Olmsted and the promise of these findings letters.
And thank you so much, Mary, for that. And thank you again for emphasizing towards the end about the equity portion, because that resonates for everyone. So thank you so much for that. Now, Dr. Thompson, I know you were in the hot seat earlier. You have a couple of comments you would like to make about the keynote discussion?
Well, I guess what I will say is that I'm very pleased to be following Mary and the speaker from Department of Justice because they've done such a great job. There's not a whole lot more for me to say, but what I do want to talk about for a moment is to just say a little bit about the idea that we are in a mental health, I'm going to use the word mental health emergency in the United States right now. And I want to use that word advisedly because an emergency has a different connotation than a crisis, at least in terms of federal policy. The activities that we are undertaking here are more than just responding to a crisis. We are in a mental health emergency. And I think we have to be careful about how our own language can sometimes minimize the specific challenges that are facing the nation at this time. One aspect of this emergency is how poorly our crisis responses are organized, funded, and generally set up. So I think that this is a moment where when we talk about crisis, we cannot allow the notion to be that there is not a larger emergency around mental health going on. And this is something that I think comes out of what Mary was talking about in particular. We are talking about a whole spectrum of resources and capabilities to deal with the fact that we have to acknowledge that there are large numbers of people in the United States who suffer because of psychiatric challenges and traumas and various other kinds of insults to their minds and bodies that make it difficult for them to function and to deal with challenges that we in society often put on them. So if we don't develop that continuum, we are going to be continually in trouble. It is really important right now, and we obviously have a head of steam around 988, to begin to actually think about the crisis part of this as being a continuum and part of the continuum that we need to address, and that it is outside of a police response. I think the message that's clear today is that outside of situations which are likely to result in a potential threat of violence, there is absolutely no need for police to be involved in psychiatric challenges and crises. It just doesn't make much sense to bring that escalating aspect of violence into those settings. How we do that, how we learn to do that better, I think is going to be an ongoing challenge, but clearly the work that we were hearing about today has been a key part of this and is breaking the ice for the nation as we move out of a long-standing approach that really needs to change. Part of it's really got to be about how we understand what the issues are that people have when they're suffering from psychiatric challenges and traumas, and begin to realize that when people are treated well, when people are treated respectfully, when people are given opportunities and resources, it is very likely in almost all cases that people will respond better than if they are treated with force, coercion, and limited resources and opportunities. So we know that we need to put that into how we operate as a society. It's time essentially for us to grow up and face the fact that human beings have challenges. We need to learn how to help each other move forward in life and not build obstacles for some of us. And I'll just stop there for right now.
No, thank you. Thank you. Thank you. You know, there was a chat place in the chat box that says, thanks for tying all the pieces together. I think the three of you did a beautiful job in the limited time that you had and really pulling things together and helping people to understand. You can see that through the chat box. So I want to give thanks, first of all, Haley, to you for a wonderful presentation, and for Mary and for Ken, thank you so much for your comments. It really does help in this conceptualized format to take a good look at these measures. So thank you all again for your participation. And again, Ken, make sure you get in contact with us to get your t-shirt. Okay. So let's move on now. We're going to the SAMHSA update. And today, Dr. Richard McKeon is going to deliver our update from SAMHSA. Go ahead, Doctor.
Thank you so much. Can you hear me okay?
Yes.
Great to be with you today. So I will mention a couple of things. SAMHSA just released from the 988 office, Pride Shareables and a new PSA. So I wanted to make sure you were aware of that moving forward. Include 988 Lifeline Pride social media shareables. So you can go to the 988 part of the SAMHSA website to download these. I also wanted to give folks an update on the work to revise the national strategy for suicide prevention.
Okay, I'm just gonna watch this.
And we had okay, I think I'm
You're better.
unmuted now. All right. So we were glad for the opportunity to present on the national strategy on the crisis jam a couple of weeks ago. Would love to get a access to the robust chats that were done in response there. So if someone from the crisis jam can send me instructions about how to access that, we can look at that feedback and try to incorporate it. Where we are right now is that, you know, we have an initial draft of goals and objectives for revised goals and objectives for the national strategy, and also beginning to look at how those revised goals and objectives can inform an action plan that can be released contemporaneously with the revised national strategy, which is scheduled for January of 2024. Finally, just an update on the federal interdepartmental task force on military and veterans mental health, which is responsible for implementation of the president's executive order on military and veteran suicide prevention. And one of the components of that is embedding evidence-based suicide prevention in emergency departments around the country, including universal screening, which doubles the identification of suicidal people, safety planning, and rapid follow-up, which have been shown to reduce suicidal behavior and increase access to mental health services. So that work is ongoing. We're hoping that with the help of the Joint Commission has been doing a survey, which they're planning on publishing later this year, of the use of these evidence-based practices in Joint Commission accredited hospitals. So thank you for the opportunity to give a SAMHSA update.
And thank you, Dr. McCann, for your vision, your insight, and SAMHSA's leadership on these wonderful issues. Thank you again so much. We'll now move to the NASHBIT update, and it is my honor to present Commissioner Carrie Slatton-Hodges, who we're very familiar with, and she is going to give us an overview of some of the efforts coming out of the Oklahoma area. So, Commissioner.
I love your slide with all the states and Oklahoma highlighted. That's really nice. So as was mentioned, I'm Carrie Slatton-Hodges from Oklahoma, the great state of, and really I just wanted to share with you today a little bit of the work that we're doing in implementing technology into our crisis continuum of care. And I just wanted to kind of talk to you a little bit about that. What we do in Oklahoma, we have widely used tablets, or often referred to as iPads, throughout our system to really help in our crisis continuum. So if you could move to the visual that is next. So what we do in Oklahoma is we put tablets in the hands of many people. The greatest majority that you will see in the green here are persons that are served across our system. And the way that helps in crisis care is when you start in services with someone and you are in particular in a high risk group. So say you have discharged from a hospital previously, you have left a crisis unit, you have been someone that's gone to one of our urgent recovery centers, or you're a person that's engaged in outpatient care, but has a bit of a history of going into crisis, then a tablet is sent home with you that you can use in a number of ways. Number one, for just your ongoing care and treatment, which is terrific because we all know people have challenges with transportation and babysitters and all of this sort of thing. So you don't have to ever miss an appointment. But more importantly, there is a budget in the middle, that a button that has that's basically for crisis, that you can push 24 hours a day, 7 days a week, and someone will always answer on the other side. And really, even if you're just, say you're feeling anxious, you can hit that. You will get someone from your local area, your CCBHC provider. We're a CCBHC state, so we have coverage of our entire state through CCBHCs. They will answer and they will talk to you about whatever's going on. They can help de-escalate a crisis. They can help talk through whatever situation is there. They may work with a teenager and a parent in that manner. But what we've found in doing so is it dramatically reduces the number of crises that escalate to needing an admission, going to an urgent care, involving law enforcement, by putting this in the hands of people who we know have a history of crisis needs. And it really is able to handle that at the lowest possible level when that person needs it anywhere. And then, as you can see from this graph, the next group is hospitals, and that we place these tablets in hospitals around the state, especially in rural areas where oftentimes there is not a person working that that has a lot of behavioral health experience or knowledge about crisis de-escalation, or that maybe not everybody needs an inpatient admission. There are lots of other options. So hospitals use those then to push a button, reach a behavioral health professional in their area that then can walk them through, meet with that client, come up with what the best course of action is for that person, which oftentimes is a diversion from needing a higher level of care and going ahead engaging with local services. We also have these in Oklahoma in the hands of, in the car of, every single law enforcement across the state has the opportunity to utilize these. Where we found that is so tremendously helpful is that when an officer is out and they get a call and they go to a situation and there may be behavioral health needs there, mental health or addiction needs, there's a number of things they can do. First off, they push a button and they have a behavioral health professional on the other end. And they can utilize that in a number of ways. What happens most often is they just hand the tablet over to the person, allow the behavioral health professional to start engaging with that person to figure out what's going on, what may need to happen next, etc. And so oftentimes it is a complete diversion or de-escalation of what might have happened between law enforcement and that person, or what level of care that person may need. And then law enforcement is guided from there as to what next steps should happen, whether this is a person that needs to go on and have a full face-to-face intervention in some type of way, or whether this person is connected to care tomorrow morning and they're going to be okay until then, and we've got this under control. So all law enforcement officers in our state have the opportunity to participate in that. And it works tremendously. Now, one other thing I will say about the law enforcement tablets is that there is a button on there also just for law enforcement to use for themselves. And that routes outside of their district to a behavioral health professional that is not located near them. Because what we do know, when we're working to reduce suicides and to make sure that person's needs are met, law enforcement fall in a category of high risk. They experience a lot of vicarious trauma. They have access to lethal means. They're in the age and demographic of high rates of suicide. So we put a button on there specifically for them. They can use it anytime they want to interact with the behavioral health professional, talk about what's going on in their life, talk about what's going on the job, anything that they may need assistance with. And then the orange was police, and then the gold is sheriff. So you can just combine those two as first responders. And then we put them in schools. And then when you see that last one, the CMHC, that's the people that are answering. So we have people all around the state that answer these. I'll just say, if you'd like to know more about this, we did do a webinar that was a joint SAMHSA-NASHPD, and you can go to the NASHPD website and see a webinar that tells you much more detail about these. So thanks for just a brief time to be able to update you on what we're doing, and thanks for your time.
Commissioner, thank you so much. And you've always been open about really communicating with others. So I can tell you guys that she has shared this information with many states and jurisdictions, and I'm sure will be available and open to do so for anyone. But thank you for that report from on behalf of NASHPD. Let's move now to the Medicaid up front with Tom Betlock. And Tom,
can you hear me okay? Can
Yes,
you hear me
sir.
okay? All right, great. So we've covered in this area oftentimes an update in terms of how Medicaid can come alongside and help support the delivery of crisis services and expand crisis services. And today we're going to hear from Heather Saunders from Kaiser Family Foundation, who recently published a paper in terms of looking at Medicaid and how it's supporting the various services associated with crisis by state. So Heather, take it away and help us better understand in terms of how Medicaid is supporting crisis services.
Sure. Hi, everyone. I'm Heather Saunders. I'm a postdoc in the KFF Department of Medicaid and Uninsured. And it's great to be here today to share results from KFF's annual survey of Medicaid programs. Next slide, please. We sent a survey to state Medicaid officials that included questions about coverage of crisis services, state uptake of ARPA-funded mobile crisis, and implementation challenges experienced by Medicaid programs. And that's what I'll talk about today. 45 states responded to questions about coverage, and this slide covers fee-for-service adult coverage of select crisis services in Medicaid as of 7/1/22. So for the slides that I'll show today, you'll see bars with numbers on top, and these numbers represent the number of state Medicaid programs that responded positively to that particular question. So what does fee-for-service adult coverage of select crisis services in Medicaid look like as of fiscal year 2022? Overall, states report higher coverage rates for mobile crisis and crisis stabilization units, but lower rates for crisis hotlines. Nearly 3/4 of responding states reported mobile crisis coverage. 2/3 reported coverage for crisis stabilization units, and less than half reported coverage for mobile crisis services. We're figuring out how to bill for hotline services might be an issue. 12 states, including DC, report covering all 3 of these services. 20 states, we also asked about requirements for peer support services in mobile crisis teams, and 20 states report that they require peer support services as of fiscal year 2022 and 23, with some states reporting workforce shortages as an issue that prevents them from adding this requirement. It's notable that compared to other categories of behavioral health services, crisis services actually have the lowest overall Medicaid coverage rates. But this is an area that's quickly evolving as many states are figuring out how to respond to needs and integrate with 988. Next slide, please. We also asked states about implementation plans for ARPA mobile crisis services, which provides a 3-year enhanced funding at 85% federal match for qualifying mobile crisis services. And 2/3 of states told us that they plan to take up this option with implementation spread across 2022, 23, and 24. Some reasons that states gave among those who chose not to pursue this option included pre-existing non-ARPA crisis services or difficulty understanding or meeting the ARPA requirements for the enhanced match. Next slide, please. So next we asked about implementation challenges, and almost all responding states reported at least one obstacle, with a high number of states reporting challenges around workforce and geography-based challenges. So I'll quickly go into a few of these. Some top workforce issues that states reported include overall workforce shortages, difficulty finding people willing to work in crisis services, challenges staffing around the clock care, especially challenges staffing overnight, high turnover rates, and some states reported difficulty fulfilling ARPA requirements, especially the requirement for maintaining 24/7 coverage and a 2-person team. Top geography-based challenges that states reported included increased travel times to rural areas, which can result in longer response times, challenges around poor cell phone reception, and challenges around planning for staffing and how to pay for on-call time. And there were some states that reported additional planning and coordination challenges across additional agencies for working with tribal populations. Top training concerns included training requirements for new and existing staff, and also the additional staffing challenges that are created when they have to take the limited workforce out of the field to do new trainings. And these stressors intersect with the shortage of available trainings. Scope of practice limitations, mostly focused on clarity of the peer support role. Other challenges that states mentioned included funding and sustainability of funding. A few states talked about lack of coverage from other payers as a challenge, along with the temporary nature of enhanced match for ARPA, with Oregon recommending permanent implementation of the enhanced federal match for qualifying crisis services. Other challenges include effective dispatching, connecting 988 to mobile crisis teams, and provider network availability. Next slide, please. If you'd like more detail, you can take a look at KFF's website on the Medicaid page, where we have research briefs published from these survey findings, which include topics such as crisis services, Medicaid coverage of behavioral health services, where we have state level data on 55 service indicators, telehealth delivery, strategies to address workforce shortages as reported by Medicaid state officials, school-based services, and delivery and administration. On the next survey, we're going to include more questions about crisis services.
Righty, well, thank you.
Great.
Thank you.
Thanks so much, Heather. Appreciate it. As usual, Kaiser proves to be a tremendous source of resources in terms of data out there on the Medicaid program. We look forward to seeing this data get updated over time, and thank you so much for sharing.
Thank you both for sharing that information. I'm going to move quickly into our crisis talk next with Stephanie Hepburn. Stephanie.
Thanks, Brian. So I'm going to quickly bring on Taylor Crouch Dodson. Today's piece was by Taylor and Candace Hansen, but unfortunately Candace can't be here. So we'll have Kelsey Yale joining us. Taylor, if you don't mind hopping on and giving a brief summary of the article, I think starting out with the DOJ report would be a good starting point.
Absolutely. Thank you so much for having us here today. So as Haley mentioned earlier on, the DOJ released a report last Friday focused on the pattern and practice of discriminatory behavior by the Minneapolis police against Black and Indigenous communities, as well as people experiencing a behavioral health crisis. One of the key findings in that report indicated that only 0.45% of over 100,000 mental health calls resulted in an arrest at the scene, underscoring that the current reliance on police-only responses is unwarranted. That's a theme we've been speaking about all day today. And so the Minneapolis Behavioral Crisis Response Team, or the BCR, was one of the clear positives that came out of the DOJ report, which is the program that we are from, Canopy Roots, and we've been operating the program since December 13th, 2021, and we've been taking on average about 140 calls per week, which is leading up to about 8,000 calls over since our launch in December of 2021. Kelsey wants to add a few points about some of the work that we do.
Yeah, coming from working on MCTs or mobile crisis teams and other crisis centers and the old iteration of the suicide prevention lifeline, one thing that I think is really amazing about the changes to 988 and the changes in our program is how we can reinvent public safety. The majority of our calls are resolved via voluntary transportation to natural supports such as a family member's home or things like crisis receiving units or hospitals. The biggest factor that's unique to us is that we're public good, and so we have no billing involved at all, and that both allows us to freedom in hiring and in response, and really maintains our values of being accessible and low barrier, and reduces paperwork, which everyone likes, of course.
Taylor and Kelsey, can you very quickly share some of the successes, you mentioned some already, and also the challenges that you faced, both from the community and also collaborative partners?
Absolutely. Thanks, Stephanie. So when we initially launched the program, we definitely had some opposition, even within like the community. We had some opposition from even the county that has a program that's more of a co-responder model with police. Even our Minneapolis Police Department wasn't 100% on board, really because we were so committed to being an unarmed alternative response. We weren't interested in having any body armor, any form of weapon on hand, and that was really challenging what was the status quo within the public safety system. But those commitments came directly from community. Starting in 2019, the city of Minneapolis conducted extensive research and community engagement with over 8,000 residents. And they said, we want a new response. We want it to be 911 based, and we want them to be unarmed mental health professionals. And so the city was willing to commit to that. George Floyd was murdered in May of 2020, and there was a strong political will to say we need to look and see how we can expand beyond a police response. And so today, fast forwarding to the DOJ report, we were really enthusiastic to see that they really shined a light on our program and really directed 3 out of their 28 recommendations, really focused on expanding the capacity, the training, and the coordination of the program that we've been leading, the BCR, alongside our partners like 988, EMS, and other county-based programs. And so to really build out a more continuum of care model within Minnesota and the Twin Cities broadly. So we definitely had some opposition at the beginning, but over time, the model has really proven to be successful. In those 8,000 calls, we've had 0 injuries. And so we're really showing that we can look at 911 calls differently and do it safely for folks in an empathetic and trauma-informed way.
So thank you so much for hopping on the call, and I direct everyone to go check out the article. Thank you, Taylor and Kelsey. I'll pass it back to you, Brian.
Thank you.
Thank you so much, Stephanie, and thank you to Taylor. And this will bring us to a close for today's session. I just want to remind everyone about the upcoming sessions, particularly through the movement of suicide, as well as looking at some further episodes coming up, episode 133 with fundamentally transforming crisis care in Arizona. Looking forward to that as well. So to each and every one of you, I want to say have a pleasant rest of your day. Thank you for watching this Crisis Jam, and we look forward to having you come on next week. Thank you so much.